We're there, right? 1st of February 2024. We are 6 weeks away from 4 years since we first did this, which is quite a remarkable thought. When we thought this was going to, we'll do this for a couple of weeks and then we'll go back to normal. How did that plan out? So if you just arrived in the room, good afternoon, good morning, good evening, wherever you are in the world. Thank you very much for being part of this. It's the 1st of February. This is our Q&A. So taking you right back to the start, many Q&A sessions have featured the now world famous, world eminent squeaky chair and our favorite squeaky chair inhabitant, which is Professor James Neuberger. So James, hello sir, how are you?
I'm good, and thanks. It's really congratulations, because I think it was your inspiration that got these going, and I think there's some skepticism as to whether they'd be useful, needed, and continue. And it's, as always, nice to prove the skeptics wrong. And I suppose it's also worth saying it's always worth trying something.
Yeah.
And if it doesn't work, it doesn't work. But it's far better to have tried and failed than not to have tried at all. But this is where it's worth having tried, and it only continues because people want it, I guess.
100%. Now you're right. And thank you. So one of my favorite stories, lessons, is I'm sure some people will claim it's a myth, but the WD-40 and how WD-40 got its name. Do you know this?
Yeah, I do, but many of the watchers may not, so tell them.
So in really simple terms, the very nice man who invented WD-40, which has got to be in 90-something% of homes in the Western civilization. So he started with this plan, and his plan with his wee notebook was to create a water dispersant. And so on the page 1, he wrote water dispersant number 1. And he tried his recipe, and number 1 didn't work. So he tried water dispersant number 2. And then he discovered 39 ways how not to make a water dispersant. And then by the time we got to 40, we'd moved from water dispersant to WD. And on the 40th attempt, he found the way to do it. And he is on record as saying that he hadn't failed 39 times. He just learned 39 times how not to do it. And I think it's a huge lesson to all of us that, if we're not trying, if we're not making mistakes, then we're not doing the right thing. So thank you.
My father-in-law had in his home, and I've taken it now, a little sign saying, "The man who made no mistakes never made anything." And I think I've got it somewhere still. And I think it's a really important message. The other one that I quite like, just to sort of complement that, was, you probably know the story of the Post-it notes, that a researcher was working for 3M and looking for a really strong adhesive.
Yeah.
And during his his experiment found a really weak one. And he realized the potential for this, but it took many years of persuading the board of 3M that this was a successful product.
Yeah.
And finally he succeeded. And Post-it are very common now, and so stick with your beliefs, I think, is the other. Whereas again, Kodak, I think one of their team members went to Kodak board many years ago when they were still using film and said, we really need to digitize and go down the digital pathway. And the board said, no, this will never take on.
Yeah.
And Kodak is virtually bust.
Indeed. So there you go.
Yeah.
See, not only PBC, we get life lessons as well. So, thank you. Right. Okay, so if you have any questions today, please do pop them in the box. They can be here in the Click Meeting room, or they can be on Facebook as well. Please do bear in mind that we're not here today to provide specific medical advice, but we're here to give general medical information. And hopefully what we're trying to do is empower you so that in your next consultation, in your next medical appointment that you feel better empowered and better able to ask the questions you need of your own consultant in your own circumstances because of the general information that we've given. So hopefully that sounds fair and reasonable. So James, coming to you as a man who's made many mistakes. The
and
question
very
is,
few of them.
The question is in and around painkillers. So we know that there's not one answer to painkillers and PBC, but what can you tell us in general terms? And because we have time, it'd be nice to have as comprehensive an answer as possible, please, because this is something that comes up often. And I know, we've worked together for years. I know, for years you've looked at the patient holistically and not just where they are at that moment in time. So can you maybe talk to us about painkillers and PBC in general terms?
Thanks. I think there are two things. The first is with pain is to try and identify the cause of the pain. And there are many, many causes, and that's a separate issue. And I think we may come back to that, but I'll leave that for the moment. So why have you got pain? Very often it's obvious. You fell over, you break your wrist. Okay, that's fairly obvious. If it's not obvious, if it's something particularly non-specific, like tummy pain, again, it's much more difficult to know, is it serious, is it not? When I say serious, I mean, is the cause something that's serious, or is it something that's trivial? So you really want to know what the cause of the pain is. If it's obvious, that's fine. If it's not obvious, then if it gets worse, if it persists, then you need to have that investigated. The second point I want to make is that the response to pain is very variable. And it's very much dependent on, obviously, the cause of the pain, but your people's reactions to pain varies enormously. And the example I was given many years ago when I was a student in the days when gaslight meant normal living rather than what it does now. The example I was given was somebody on the hockey field or on the football field, and I'm sure a player such as Robert will know this. You'll have a nice enthusiastic game of football or whatever, hockey, and you'll come away and you notice that you've got some bruising on your shins, and you won't know how it got there. Somebody kicked your shins, ball particularly hard, collided with goalposts, what have you. But there's been a trauma that's resulted in bruising, and you may notice some pain, you may not. Now, if you contrast that with saying, right, let's stick with the football example, say an 18-year-old male, okay, you choose them out of the class and say, in half an hour, I'm going to kick you on the shins. And it's 5 minutes to go now, so stand up on the desk and get ready for it because I'm going to kick you. And the pain you would start to feel the pain, I suspect, even before you were kicked. And that was quite a good example for me in my sporting days, believe it or not, they were there, of how subjective aspects can affect how you perceive pain. And again, we see that all the time with people, say, undergoing surgery, where the stimulus is the same, but people's responses are very variable, and many factors go into that. The second point I'd make about pain is only the person know whether they have pain or not. It's no good, we can argue whether somebody's jaundiced or has got ascites, but what we can't argue with is whether you've got pain. There's no objective assessment of pain. you know if you've got it, and if you say you've got it, then people have to believe it and act on it. So it's variable, it's subjective, and that's not to denigrate it. But, and for example, if you're depressed, if you're anxious, if you're stressed, then the same pain will seem a lot worse. And that again is natural and understandable. There are measures of pain, and when people go into hospital, say for, to look at post-operative pain, there are scales, and you're also rated on usually 1 to 10. That gives you some guide, but again, what really is, I think, is a healthcare professional, you're looking for the changes of the pain, because your 6 and my 6 may be different. So it's difficult to measure because it's subjective, but that is not to say that it's something that should be taken very seriously, irrespective of the cause. And there is no correlation really between the severity of the pain you have and the severity of the cause. So, for example, I don't know, cancers are often painless, and trauma is something that's happened, no damage has been done, you're in pain, and it'll get better. So it needs to be taken seriously if it's affecting your life. I think sometimes people have an unrealistic approach to pain and to expect to be pain-free. Ideally, yes, but sometimes it's worth putting up with a background of mild pain, but that's up to the individual to decide how much is tolerable, how much it interferes with their life, how much they want to have interventions. When it comes to treatment of pain, again, it's very important to remember that pharmacology, drugs, is only one possible treatment. Psychological support, cognitive, is again a useful adjunct. Some people naturally and sensibly are worried that they have pain and there's something serious going on. And if you can allay those symptoms, that makes sometimes the pain less severe. Sometimes cognitive behavioral therapy or alternative treatments, ways you can learn to deal with the pain so that you can lead a normal and fulfilling life. I don't think that applies to an awful lot of people, but again, it's one thing to think about. Another thing I would say is don't underestimate the role of physiotherapists. They have a huge potential. They have great knowledge. I think in the NHS, certainly, they're often undervalued and underused and overworked. But they do have a lot of knowledge, a lot of experience and techniques to deal with pain and to know which one is likely to work. Particularly, I'm thinking of soft tissue injuries, sports pain, and those sort of things, but also the pain of arthritis, of rheumatoid, and so on. Don't underestimate what they can offer. They will also offer, in some cases, exercises, I should say, to strengthen the muscles, and that in some cases will again help support the joints or other tissues and enable you to live with the problem more effectively. So physiotherapists have a lot of different treatment options available, like ultrasound, hot wax, and so on. And they have expertise in knowing what is likely to work. So consider those experts. They may be appropriate to give you advice and even treatment. Other forms of treatment certainly can work. Acupuncture, I was quite skeptical about acupuncture, I have to say, but there have been a number of studies now showing that it does work in some people. And the studies that are more convincing to me were those with sham acupuncture. So this was done either with, this was done using needles, if you like, in the wrong place or the wrong needles, and showed that people who had acupuncture delivered by acupuncturists had much better pain relief. So it may work for you. And I've read, I'm sure other people have too, of the experiments of people having childbirth under acupuncture, and I think it does work for some people.
Okay, perfect, thank you. And in terms of Western medicine, sorry, on you go.
Oh, yes. So coming back to pharmacological treatment, again, that has a place. And the key thing, I think, about all treatments, whether psychological, physical, whatever, is different painkillers work for different people at different times. And it's a matter of seeing what works for you. I said earlier on, and I'm sure people agree, that pain is very subjective. You know what pain you've got, you know how it affects you, and you'll know then whether treatment is working. Yes, for pain relief, as in any other treatments, there is a placebo effect. We see that in numerous trials, that people get side effects from placebo. But again, if it relieves the pain, whether it's a placebo effect or not, does it matter? The answer is no.
Yeah.
So what do you use in terms of pain relief? Now, essentially, there are two ways you can deliver pain relief. Well, three, I suppose. One is topically. That means you apply it to the skin. And that can work. There are two types of preparation, if you like, broadly two preparation types. One is the gels that you can buy. Ibuprofen gel is a classic one, or I believe anisole, again, is another topical pain relief for piles. You apply it topically, and it does in some cases help. The theoretical advantage of topical treatments is you can apply them more frequently, and you don't absorb the active ingredient to such a significant extent. You can get, for example, we use these a lot in people with severe pain, patches. Again, the active compound, often something like morphine, is applied on the patch that's put on the skin, and it gradually gets dissolved through the skin and works. It has many advantages. It's easy to take. You can apply it, but absorption is variable. Some people have thicker skin than others. It depends where you put it on and so on. But that's another way that works for some people. There's intravenous pain relief, such as you might have following an operation or for other reasons. And then there's oral medication, and oral medication, there are various preparations. You can take them, they can dissolve in the mouth, often under the tongue. You can take them as tablets, you can take them as capsules. There are some differences in price. There are also differences in speed of onset. Now, really, you have a hierarchy of pain relief, and the usual thing is to start with the simple analgesics. In most cases, obviously, if you've had a hip replacement or major abdominal surgery, then you're not going to start with paracetamol. Although, again, going back to my days doing obstetrics, I was absolutely staggered that people who'd had childbirth was just given peppermint water, I'm surprised nobody threw it back in the midwife's face, but anyway, that was what they did then. Paracetamol and the so-called NSAIDs, non-steroidal anti-inflammatory, are the two entry-level drugs. Paracetamol is good and safe. It does have a slightly bad name, particularly with liver conditions, because an overdose of paracetamol can lead to liver failure. So if you're taking paracetamol, you want to limit to probably 6 or at the most 8 tablets of 500 milligrams a day and take no more than that. Paracetamol is usually well tolerated, and if it works, that's great. But I often prescribe medication, and do remember it doesn't work in the bottle. You have to take it by mouth. It's surprising how many people are prescribed analgesics and don't take them. But take them, if you're going to take them regularly, take them as needed, and take them before the pain gets too bad. You know the pain, you'll know how it affects you. And if you know the pain's going to come and get worse, sooner is better than later. It's usually easier to prevent pain getting worse than to treat bad pain. Now, the other group of drugs are the so-called non-steroidals, of which Brufen, ibuprofen, Nurofen and aspirin indeed are the classic ones, but there are many Me Too type drugs. They have to be used with caution in people with liver disease from any cause. They can be very effective, but people with liver problems are more susceptible to the side effects of non-steroidals, particularly for gastric irritation, and your doctor may suggest you take a drug such as omeprazole or esomeprazole as well to reduce the gastric irritation risk. But they can also damage your kidneys, and too much non-steroidals, particularly in those with liver disease, can cause renal damage, and that can either be acute or it can be long-term. And we do see what's called analgesic nephropathy in people, not just with liver disease. So if you are taking medication, so be careful if you're taking non-steroidals, and it's probably best to ask your doctor, how safe is it for you? Often if you have very early PBC, then it's probably reasonable. If you have late PBC or other liver disease, it's more hazardous. But talk to your doctor and get their steer so you know for the future. Paracetamol and non-steroidals can work together. They act differently, so you can take both at the same time. But I slightly worry as to people doing that because the pain must be quite severe for that. Another drug that people often give for chronic pain is something called amitriptyline. Now, this is a drug that was used primarily for antidepressants, and it was quite an effective one, but we have much better ones now. But at low dose, I'm talking about 25 milligrams a day, that sort of dose, you'd give 250, 500 for depression. For low dose, they do act helping the effect of the analgesics. So if you've got ongoing pain, sometimes amitriptyline can help. It's not to treat a depression. It's not saying you're depressed, although long-term pain can make you depressed. But the amitriptyline is there to help the pain relief work, not to treat any depression. If there is depression, that's something different, and you need to treat that and treat it properly. And whether you do it by CBT, behavioral therapy, medication, or combination is discussed with your doctor. If those don't work, then again, there are other drugs that you can give to help relieve the background pain, and your doctor will discuss that with you. Then really, for most people, you're going on to the morphine type drugs, the opiates, and that's quite a big step up. They do work very well for some people. They are very good pain relief medication. There's the major concern of addiction and dependence. And we've seen in the States the horrific consequences of that. So in the short term, that's not a huge problem, although it's a worry. But in the long term, it's something you clearly have to guard against. And when you're going to those levels of drugs, opiate dependence is a very big worry. They do have other side effects. They're quite good at constipating you. And particularly if you've got advanced liver disease, that's bad news. You need to avoid that. They can make hepatic encephalopathy worse. They can also have numerous other side effects. But those sort of opiate drugs have to be given by prescription, and your doctors will, I hope, go through the pros and cons with you and adjust to your case. So if you are going to have analgesia, start simple ones, paracetamol. Topical non-steroidals are probably okay. If paracetamol doesn't work, talk to your hepatologist or nurse or doctor and see whether non-steroidals are appropriate for you. Look at other physical measures, heat, physio, whatever, to see if they will complement, not replace. And I would finally say, sorry to the end, is that pain doesn't ennoble the soul. It doesn't make you a better person. It just makes you worse to live with and ruins your life. So take it seriously. Make sure it's taken seriously. There are pain clinics, but they're huge waiting lists. But severe pain that impacts your quality of life needs to be taken seriously with a stepwise approach and adjusting it, see what works for you. And if one treatment doesn't work, try another. So it's a complex area. People are getting better at it, at understanding the implications, but it really does impact on people's lives and needs treatment.
Okay, perfect. Thank you very much. That was fantastic. Thank you.
Long, I don't know.
No, that's great, and that's brought a huge amount of detail, and I think that's a really clear, not just an answer, but a whole subset of answers. So thank you for that. We've got somebody who the comment just says, "I'm F4 and very scared." So let's address that. How would we start? So can you talk a little about F4? Talk about the difference between kind of cell change and cell damage within the liver, and how that doesn't necessarily correlate with biochemistry, and maybe say a little bit biochemistry being the indicator for in terms of the future and not the past of a patient's PBC journey.
Right. If you're just before we start on that, can I just say one thing? That if you're scared, you've done firstly absolutely the right thing to contact the PBC Foundation, because that is one of the probably that Robert may correct me, probably one of the main reasons why the foundation was started, to provide support, because the fear of the unknown is far worse than anything else. People can put up with bad news, but far more effectively than you can put up with uncertainty. So you've done exactly the right thing by getting in touch with the foundation and talking things through. And obviously that's a private matter, and I'll leave that to the experts anyway. But you've done exactly the right thing, so well done. When you're assessing the liver, it's rather like assessing, say, a car. For a car to work effectively, you need all sorts of components to be working properly. And different aspects of the car can run into problems, and the car can either stop working, can be a danger, or can work reasonably well. So, not to push the analogy too far, if the heater doesn't work, you can probably manage, you can drive safely and take an extra coat and hat. So, but if, say, it's the electrics, you're in trouble and so on. I don't take that analogy too far, but there are different components to the liver, and in PBC, as with other liver diseases, different components are affected at different rates and different significance. The F4 refers to the degree of fibrosis, and that's the amount of scarring in the liver, the amount of scar tissue that affects all the way across the liver. And the higher the number, the more the scarring. And mostly we assess scarring by one of two means, predominantly by FibroScan, but also there are a few blood tests that can be done that can assess the degree of scarring. And there is no doubt that as the fibrosis, the scarring progresses, as the disease progresses, the fibrosis progresses too. That said, the fibrosis, if it leads to cirrhosis, can, or even without cirrhosis, can lead to portal hypertension, which is where the pressure in the vessels to the liver, in the veins build up, and you get the complications potentially of varices and so on. So it's something that we note. Most people with F4 don't have these problems, but it's something that will alert your doctor to potential problems that, if known about, and this is a key thing, the complications can be treated or prevented. So it is an important thing. Yes, to be absolutely blunt, would you rather be F1 or F4? The answer is obvious. You'd rather be F1. But if you are F4, yes, it doesn't mean your liver's in danger of packing up imminently. It doesn't mean there are problems that can't be solved. And I think, and I know it's easy for me to sit here and say this, is to look upon it as it's nice that it's found out, so that your doctors and so on can be aware of potential problems and prevent them from becoming problems. The actual, so the liver is composed primarily of what are called hepatocytes. These are the liver cells, and these work to metabolize drugs, metabolize compounds, make new proteins, metabolized by bilirubin and so on. They're the, if you like, the powerhouse, the energy of the cell. And those cells in PBC are much less affected than they are, say, in viral hepatitis. With hepatitis B or hepatitis C, the virus damages the hepatocytes. With PBC, yes, the hepatocytes can be damaged, but much less so, because the target of PBC is the bile ducts, which are primarily, but not entirely, the tubes that carry the waste products away from the liver cell right into the loo, if you like. So if you have scarring, it's rather like, I suppose, the streets of London or Edinburgh when they were building the tramway system. Things can work pretty well. It's a nuisance, but you can circumvent. That may be a slightly false analogy, but having been to Edinburgh when the trams were being built, it was pretty disruptive. But, again, it had a pretty good outcome, I think, for certainly visitors.
Okay.
Anyway, And then they're the markers of how the liver is performing. And there are various measures of that. Now, Robert alluded to the blood tests. Now, what we know is that one of the most useful blood tests to know the prognosis is the alkaline phosphatase, which is a chemical released primarily by the bile duct cells. And again, you'll know this, Robert knows this far better than I do. If your alk phos normalizes on treatment, your prognosis is very good. So the F score is measuring fibrosis. It's not telling you a huge amount about the prognosis, what's going to happen. And blood tests are useful. But again, remember that you're being treated not as an F4 or as an alk phos or as a person or as a liver problem, but a person with PBC. And you have to assess the whole picture, the whole person, because you can, I've seen people in those awful biochemistry who are working normally, functioning well, and so on. So it's the whole thing. Yes, it's important to know you've got F4. Yes, I'd rather have F1 than F4, but it's manageable. It's doable. You can still cook a hard-boiled egg. You've got a good, a reasonable future, a good future in front of you. It depends on, if you're 95, that's different from if you're 12, and so on. So I'm not going to go into detail for you, but talk to the foundation where you can give them your personal details, much more related to you, and they can explain what it means. The answer's not always necessarily what you want to hear, but once you know what you're dealing with, then you can get your head around it and adapt to it. But I would much rather have F4 with a normal alk phos than other combinations, put it that way.
Absolutely. No, thank you. I appreciate that. And just to reiterate, if you have asked that question, please do get in touch with us directly, because we can absolutely help you in your journey here. So thank you. Cracking question. So with nearly 4 years, and I've never seen this question before. So I'm going to go up to it and scroll up so I ask the question accurately. So somebody has PBC. They also have severe psoriasis. And what they find is when their psoriasis gets worse, their liver results are adversely affected. So the question is there a connection or an effect on PBC from inflammation elsewhere in the body? That's a cracker.
It's a cracker. The answer I'm going to give you is tentative.
Okay.
And I think the answer is probably yes, because we know with other liver problems that, say, concurrent infections, that if you say have, I don't know, hepatitis B, or correlated liver, that if you get a severe infection, your liver tests are likely to get worse. There are more subtle interactions because of the mechanism of psoriasis and the lymphocytes involved. But I think in general, I would not be surprised if your liver tests get worse when your psoriasis or intercurrent problems deteriorate. The other thing that I would just mention is if your liver tests get worse when the psoriasis plays up, just make sure that there's nothing else associated with it. It's not, for example, drug toxicity, the treatments that you're taking to help the psoriasis, which are now hugely better than they were. So yes, it's possible, but don't assume it's that. Discuss it with your doctor or nurse and just reassure yourself that you're going to attribute it to the fact and of course, if with psoriasis, which sometimes does tend to come and go, that if you see the same pattern repeating itself, that'll give you more confidence. It doesn't mean your liver's getting worse. It just means that the liver's struggling, having to deal with two problems at once rather than one. So the chemicals in inflammation are systemic. That's why if you have cold or flu, you feel so rotten in your legs and so on. And that affects your liver as well. So yes, it's quite possible, but don't assume it's that without considering other options first, is my suggestion.
Okay, perfect. Thank you. Right, we've got a question now from a gentleman. So again, if you've asked this question, have your pen and paper at the ready. So initially diagnosed with PBC in 2021, but the most recent letter from their consultant refers to PSC. Now, I absolutely acknowledge that we cannot in any way, shape, or form diagnose or do anything like that at all. But can we give some general information on what the differences are between PBC and PSC? And then maybe highlight the diagnostic tools. So maybe this person can ask more questions to get a definitive answer.
Right. I suspect the most likely explanation, or one explanation you just need to consider, is that there was a typographical error, and the doctor or whoever wrote the letter and signed it, or the secretary wrote it and the doctor missed it, or the doctor didn't. Certainly in Birmingham we have automatic dictation, and so just check it's not an error. But there are huge differences between PBC and PSC. They've got, initially I can think of, do it this way around, two similarities. One's three initials with P and C in them. And the second thing is they are both a disease of bile ducts. Now, in PSC, sclerosing cholangitis, this is a condition that affects men and women far more equally. It affects children as well as adults, and 90% have associated inflammatory bowel disease, primarily colitis, sometimes Crohn's disease.
Yeah.
In PSC, in sclerosing cholangitis, in most cases, not every case, the whole of the biliary tree is involved, and you get narrowing and widening, what's called stricturing and dilatation of the bile ducts. And you make the diagnosis by imaging the bile ducts. We used to use ERCP a lot, that's where you put contrast into the bile duct through the endoscope and take X-ray pictures.
Yep.
Mostly now it's diagnosed using the MRI, so-called MRCP. In PBC, the biliary tree may appear normal. It's the small ducts that are affected in PBC. The antimitochondrial antibody is negative. The progression is quite different. PBC is normally, again, particularly without treatment, is a slow progression. With PSC, with sclerosing cholangitis, it fluctuates a lot more. You get episodes of jaundice, remission, but it is progressive. The treatment is also different. Urso, which is of such benefit in PBC, has relatively little, if any, effect in PSC. So they are quite different diseases, different symptoms, different people affected, different outcomes. So you need to understand which one you've got, whether it was a typo. There is still some confusion. Sometimes the appearances do get it wrong, particularly if people who have anti-AMA negative PBC, because there are variants of sclerosing cholangitis where the biliary tree is normal to begin with and so on. So there can be overlaps, particularly at the early stages of both diseases, overlaps in that doctors aren't sure which one you have. But anti-mitochondrial antibody is very unusual in sclerosing cholangitis, and the imaging of the biliary tree, if it's abnormal all the way down, then it's unlikely to be PBC. But check with your doctor or the person who wrote the letter. The chances are, and don't exclude it was just a typo that was missed. And it may be as simple as that. It may be that, people are different, everyone's an individual, and what they thought was one actually turns out to be the other. And then you need to know what that implies for you, for the treatment, for the prognosis, and so on.
Yeah, no, perfect. Thank you. And again, if you did write that question, again, please do get in touch with us directly, and maybe we can help you in terms of formulating some of those questions. Number one being, is it a typo? Okay, I won't mention any names, but we have a lady who's writing in from Ontario, who's watching it right now, and says, "Hello, Professor. The last time we spoke was when I was under your care at the hospital in Birmingham 20 years ago. So, 20 years since her second liver transplant, is she okay to discontinue tacrolimus?"
That is something that you have to discuss with your clinicians. I would, in general, I am very reluctant to advise discontinuation of immunosuppression. Yes, it is true that there is a small proportion of people who can safely discontinue their immunosuppression after a liver transplant. And it is true that tacrolimus, like other medications, have side effects. But there is, I would absolutely emphasize the importance of talking it over with your doctors, understanding why they advise you to continue with immunosuppression, what the risks are, and people who have stopped their immunosuppression for one reason or another, or reduced their immunosuppression. I've seen a number who run into problems with not only rejection, but graft loss. So I'm very glad you're doing well at 20 years, but talk it over with your doctors. And I would strongly urge you not to make any changes in your treatment until you've discussed it with your clinicians, understand why you want to do this. They would need to know why you've had a second transplant. People who've had rejection and graft from rejection, for example, are at much greater risk of developing rejection again. What other immunosuppressants are you on, and so forth. It's a whole issue. And if you do agree with your doctor to stop or to reduce your immunosuppression, that has to be very carefully monitored, and you need to have all that in place. If you stop and you reject, the chances of you being regrafted are very low, even in Canada. So by all means, challenge your doctors. Say, why am I still taking this medication with all its potential side effects? Is there an alternative? And be reassured that if they say you should advise you to carry on, you understand and accept the reasons for it. So always, and this applies to anybody listening, do challenge your doctors and nurses as to why you're taking medication, but don't stop it unilaterally until you understand the consequences of doing that. There may be benefits. And as I say, yes, people after 20 years, one of the factors that suggests a good outcome of stopping immunosuppression is time after transplant. That's absolutely true. But most of the transplant centres that are doing weaning of immunosuppression will exclude those with autoimmune disease because they have a higher risk of rejection anyway. So challenge your doctors, ask them politely, or not indeed, why you're still on it, whether there is an option to try and come off the immunosuppression, how you would manage to do that, what the risks are. Yes, of course, it's your decision at the end of the day, whether you take your immunosuppression or not. That's quite rightly your decision. But if, as I say, you stop unilaterally against advice and develop severe rejection, the chances of you being regrafted, I think, will be quite small. So it's a potential life or death decision.
Yeah.
But do challenge, because doctors, particularly, most doctors like being challenged and asked to justify what they do, and it's right that they should be.
Okay.
Yeah.
Perfect.
But good luck with the future, and perhaps another 20 years, if I'm still alive, you can update me and say how you're doing.
Wonderful. Right, a two-part question. Number one, completely selfish reasons. What is a PPI? And number two, is there anything better for erosive gastritis than a PPI?
Right. In this context, there are many private patient investment, public partnership, and so on involvement. But a PPI in this instance stands for a proton pump inhibitor. Okay. Now, in the early days of peptic ulcer treatment and gastritis, there was a very strong belief that it was caused by acid. And that's why people took antacids to treat the symptoms of peptic ulcer. And when people got severe peptic ulcers, stomachs were removed. And I still remember the days when people had gastrectomies for severe peptic ulcer. Then along came the H2 blockers, the histamine blockers, like cimetidine and ranitidine, and they were pretty good at reducing the acid output. And then the third generation was the PPIs, the proton pump inhibitors, of which omeprazole was the forerunner, and there are a number of Me Too drugs such as esomeprazole and so on that are broadly similar. They have a different spectrum of side effects, but they are remarkably effective at switching off acid production.
Yeah.
Now, just to complete the story of peptic ulcer, we now know that peptic ulcers are mostly caused by an infection with Helicobacter pylori, an infectious cause. And so people who have peptic ulcer disease with Helicobacter, you go for eradication, which is usually a two-week course of 3 drugs, give or take. PPIs are very good for gastritis, and they probably, for most people, are the most effective ones at reducing acidity, reducing acid production by the cells of the stomach. And it reduces the secretions as well. So they're quite good for gastritis, they're good for ulcers, they're good for hiatus hernia because they reduce the acid output hugely. The usual dose is 20 milligrams of omeprazole. You can get them over the counter from the pharmacist. They need to make sure that it's just a peptic ulcer or gastritis. And as I mentioned earlier with the non-steroidals, if you're taking long-term non-steroidals, then many people will advise concomitant use of PPIs. But it's omeprazole, and that class of drug, proton pump inhibitors, they just switch off acid secretion by the stomach cells, and it can be very effective in the right treatment.
Okay, perfect. Thank you. So unlike political Q&As, we do welcome follow-up questions. And the follow-up question we have is, does a flare-up of rheumatoid arthritis, could that also link to an increase in alcohols?
I don't know the answer to that fully. I wouldn't be surprised if it did, on the same grounds that inflammation leads to liver abnormalities in many cases.
Yeah.
But I don't have the confidence to say definitely yes or not. I wouldn't be surprised, but my knowledge, I'll look it up later. And if I can find an answer, I'll pass it back to Robert. But I don't know. I wouldn't be surprised if it did.
Okay, perfect.
But that's not a definite yes by any stretch.
All right, I hear you. Okay, we've had, I'm just aware of time, so we'll try and squeeze a couple of quick fire in. I've been put on bezafibrates after not responding to URSO or to OCA. Are there any known side effects of this drug?
Yes, there are. Like all drugs, they have side effects. If you read the leaflet that goes with the tablets, you'll get a comprehensive list of potential side effects. It doesn't mean you'll get them, but they list them there. And I would advise everybody to read what's called PIL, the patient information leaflet, which does give you the side effects, which are the important ones to get alarmed about. But I think the assumption is that all drugs have side effects and some have benefits is worth remembering. So yes, and as always, you have to balance the benefit and the risk. And if in doubt, talk to your nurse, talk to your doctor, and see so that you can make the decision what you want.
Yeah. Okay. Perfect. Thank you. I'm just going to add here, just for information, really. So we have ursodeoxycholic acid, which is our licensed first-line therapy. We have obeticholic acid, or OCA, which is our licensed second-line therapy. But we know that some clinicians, for some reasons, many of which are perfectly valid, will also use off-label fibrates, particularly bezafibrate, fenofibrate. And what came out at AASLD is that people who had not responded to URSO and not responded to either of the second-line therapies, when they went on the triple therapy, almost all patients improved significantly, which I think is fascinating, particularly when we've got two new drugs coming out. And I'm more wondering aloud in terms of what this means for the PBC population, particularly those that have not managed to respond to either first line or second line therapy. So I just wanted to share that information that that we've kind of witnessed being published at the AASLD Congress. James, you know more about this than I do. Any thoughts, any observations on that?
Not a lot. I think it emphasizes the importance, firstly, of being treated in a specialist center where they know about these things. So it's not just a matter of looking up in a book saying, oh, the licensed this is a treatment protocol.
Yeah.
So to go to a center where they're experts. Secondly, it emphasizes the importance of patients knowing about this so they can ask the doctor. And we're now starting to, I suppose the paradigm with HIV and then hepatitis C, where you found that combination of drugs, I suppose with TB again, looking back even further, that combination of drugs are far more effective in some cases than the single drug. If they work and again, ursofibrate, OCA works slightly differently. And sometimes you get the synergies of the different approaches being greater than the whole.
Yeah.
So that's why we need to have people who are investigating. We need to go outside the known paradigms, but in a controlled way, so that you can, if you like, learn and either say this didn't work or this did work and move forward. So if you're a URSO non-responder or intolerant, it doesn't mean there's nothing further to be done. And in the good units, they'll always not accept no for an answer, if you will, go that extra little bit, and finding that sometimes combination therapy, as I mentioned, paracetamol and brufen can work quite well together, and you get the synergy of the two acting in different ways, producing a better result than each of the whole. It's a lesson for life, actually, as well, I think.
All right, perfect.
We're better together than on our own often.
Indeed. So we started with life lessons, we finished with life. So speaking of good units, we've got it's more a comment than a question from somebody who's been referred to the Queen Elizabeth Hospital in Birmingham, which I can tell you has improved remarkably in recent years.
Since I retired, yes.
So they're saying the gastros ruled out PBC because they have negative AMA. The biopsy was not entirely clear. They did see mild fibrosis, raised LFTs for years. I can never say this word. Xantholasma,
yeah.
Xantholasma, but normal cholesterol. So I think there's just a concern there. What I would say in the interest of time is that if you are going to go anywhere, then the Queen Elizabeth is a remarkable place to go. It's a centre of excellence. We've worked with their fabulous clinicians over many, many years. I can't remember who the other guy was who used to be there, but he's yes, absolutely. So if you're going to go, they will absolutely get you, the answers that you seek.
Can I just add, thank you for that. But one thing that's important is if you don't have a clear diagnosis, it's far better to say, I don't know, because once you give somebody a diagnostic label, doctors stop thinking about it.
Mm-hmm.
And if you don't know, it may turn out to be one of many different conditions, genetic, PBC, PSC, drug-related, whatever. But I've seen so many problems come because somebody gets a probable or possible PBC diagnosis, gets transferred as to PBC, and then people stop thinking and say, why isn't this person behaving in this? So to keep an open mind till you have a clear diagnosis, it's frustrating for the patient, I appreciate, but it's exactly the right thing, because once you get a label, it's hard to, it should always be re-examined, absolutely, but it isn't. So it's better to say, I don't know yet. And so you can do more tests, find out what it is and get the right treatment. So although it's frustrating not to know, because people will assume you're alcoholic, put up with an unknown, provided it's being investigated and you remain reasonably well during that time.
Okay, perfect. Thank you so much. So we've got a couple of questions that have come in, and what we'll do, we will hold them off until the next Q&A that we have. There have been a couple of questions about cholesterol that have come in. We actually had a Q&A session last week. I don't know if you've heard of this guy, James, Dr. Palak Trivedi.
No.
Who's working at the Queen somewhere? I don't know. So, so I'm saying that. So James and Palak know each other. Have known each other for many years. Worked together for many years at this Centre of Excellence at the Queen Elizabeth. So Palak did a really nice section on cholesterol last week. So you will find it here on Facebook, or you will find it on our YouTube channel. So if you go onto YouTube, look up PBC Foundation, and you'll find a whole series of Q&As, and this one will be up there as well very, very shortly. So if you joined us today on Facebook, thank you so much, and apologies if you had one or two questions that we didn't get to. If you've joined us here in the room, again, thank you so much. Great to see you in here. Great to see how busy it was today. And James, thank you so much.
Nice to meet you. Thanks. Okay.
So, okay, right. I'm just going to close everything off and thank you all again. So we're just going to end the live video and save that. And we're going to